Good evening. My name is Faris Hussain and I'm one of the Medics.Academy Fellows. Tonight, I have the pleasure of introducing Dr. Lucy Morris. Dr. Morris is a GP working in South Wales and is going to be delivering a talk this evening on motivating behaviour change. As the lead for communication skills at Cardiff University School of Medicine, she is aptly proficient in teaching medical students how to communicate effectively. This talk will give you a valuable insight how you can motivate patients into changing their behaviours, whether in regards to smoking or alcohol consumption. As always, feel free to message any questions on the FDocs Slack channel. I hope you very much enjoy the talk this evening. Over to Dr. Lucy Morris.
Okay, good evening and welcome to this talk tonight on motivating behaviour change. My name is Lucy Morris. I'm a GP. I work 3 days a week as a partner in a general practice in a busy practice in South Wales. And I'm also lead for communication skills for Cardiff University, which I've been in post for the last 3 years, but I've been delivering communication skills teaching for some 10 years now. And I have a background and a special interest in substance misuse as well. So hence my interest in motivating behaviour change. So the purpose of the presentation today is to think a little bit about our opportunities to help patients with behaviour change, think about what we're trying to achieve, spend some time considering what the barriers are to us achieving, supporting patients with behaviour change, and thinking about the opportunities of when and where we can actually motivate this behaviour change, and some of the strategies that we might want to use for our patients. It was Henry Ford who said, "Whether you think you can or you think you can't, you're right." I see our role as healthcare professionals in trying to nudge patients from the mindset of thinking they can't achieve something to thinking that they can. Now, classically, when we think about behaviour change, it relates to things like alcohol intake, smoking, diet, physical activity, the amount of exercise that our patients take, and even sometimes thinking about perhaps risky sexual behaviour. I think sometimes we forget what proportion of illness can actually be caused by lifestyle factors. I think it's quite alarming to realise that as much as 80% of heart disease, stroke, type 2 diabetes, and up to a third of cancer could actually be avoided altogether if patients made the appropriate changes in their lifestyle, including stopping smoking, having decreased alcohol use, and exercising for 30 minutes 5 times a week. My concern is that I think amongst medical educators and perhaps doctors as well, behaviour change has always been considered more as nice to know rather than need to know. When I was thinking about this presentation for junior doctors in the context of living through a global pandemic at the moment, I can imagine this is probably one of the last things on your list of subjects to brush up on. However, when we even look at COVID, we're seeing that patients who have less healthy lifestyles do much worse when they get COVID. So I would argue that this aspect of medicine, motivating patients to make these healthier decisions, is actually possibly going to save more lives than a lot of the other things that we do for our patients. When we look at things in context, we can see that when we're talking about premature death, smoking is by far the largest cause of premature death in the UK. Things are changing, smoking rates are dropping, and that's often to do with measures that actually are more widely distributed, such as public health measures and environmental factors, including smoking bans. And of course, now we're seeing rates of obesity rising. So in 10, 20 years, this chart will probably look very different. So we know that the harm is clear. We know that these unhealthy behaviours have quite serious impact on our patients' lives. So I thought it's useful to take some time to think about what stops people making these healthy choices. And the list is very long. This is only really scratching the surface of the barriers that patients face. As doctors, we're very fortunate to have excellent health literacy. We understand how the health system works. We understand what affects our health in a positive way. And if we choose not to take those steps, then it's not through lack of knowledge. Unfortunately, some of our patients don't have that same luxury. They may be completely unaware of risks of their lifestyle, or even if they are aware of the risks, they may not know how to access the correct support to help them achieve a healthier lifestyle. And also, a lot of times when people make unhealthy choices, they're not doing it deliberately as a sort of, way to sabotage their health. They're doing it because for them that is a coping strategy. It's a way to manage challenges that life has thrown at them. We know that people who have more adverse events as children tend to be those who are more at risk of having alcohol misuse or substance misuse, for example. But it's more complex than that even. The cultural pressures. The United Kingdom is a society where alcohol is seen as part of a social norm, and there's often quite a bit of peer pressure for people to drink in particular, but also other unhealthy activities. And this is really everywhere. I mean, for those of you who have seen the film Grease, who can't remember the end of that, where the girl gets the guy by taking up smoking to try and impress him. Luckily, I don't think that would be allowed nowadays, but the peer pressure is immense, especially on the younger members of society. Other barriers can be things like financial restrictions. There's a lot of perception that to eat healthily costs a lot of money. To get fresh fruit and veg can be more challenging, particularly if you don't have access to transport and you can't, perhaps do a big shop in the large supermarket. You might be committed to having to shop locally in small shops with poorer choice of food. And then you're thinking about other things, including, do you live in a city, do you live more rurally, and the impact that those have. And more nowadays, we're considering misinformation. People may try and inform themselves about healthier lifestyles only to find some quite misleading things online. And you can end up in an echo chamber where you socialize with people online who have similar views to you that just emphasizes your misinformation. It can be quite hard for doctors to challenge some of that information as well. And what you'll find is that people are prone to cherry picking the information that fits their own narrative. They could be shown 100 papers on why alcohol is bad for you, but they'll find the one example of alcohol improving gut health in certain cases, and that will be the one they stick to. I certainly remember when I was a student in med school having a colleague who was a smoker, and he knew that smoking was bad for him, but he also knew that people who smoked had lower rates of ulcerative colitis, and that was the one fact that he kept telling us about. So students and doctors, we're not immune to these barriers for our own health, our own lifestyle choices. And it can be difficult for us to process information. I thought it might be useful for me to have a check of my own understanding of things. So I looked at the food choices that I make. I looked through my fridge and I thought, here we are, Activia. Everybody's seen the adverts. We all know that this is great for your gut health. It's got prune in this one. It's definitely, it's got to be practically a health food, hasn't it? So I thought, yeah, great. And then I looked a bit more closely. And I was quite surprised to see that one pot of yogurt contains 17% of my daily allowance of sugar. Now, they've instituted a traffic light system to try and make food labelling more simple, but it is voluntary. And I wonder if the makers of Activia have perhaps rather deliberately put their food values on a green background, so that at first glance you might think, great, this is all green on the traffic light system. But closer analysis shows that it's even describing itself as yogurt with sugar, and sugar being the second ingredient after yogurt. So perhaps my good intentions weren't quite so good after all. Do my children fare any better? I got them these tasty yogurt flakes. They've got yogurt in, they've got real fruit. It's got to be good for them. I'm not sure I'm going to be buying these again. The main ingredient of these is sugar. And then sugar can be misnamed as other things, fructose, glucose syrup. It's all still sugar. So perhaps I'll move on to Yoyos, which are just 100% natural ingredients with no added sugar. They've got to be good for you. They're just sugar. Still not entirely sure what's happening with this leaf on the bear, but anyway, they've got me. I'm totally sold on the Yoyos for kids. They've got to be healthy. Except then I had a chat with my friend who's a dentist who cringed when she saw me giving my kids Yoyos, because apparently this is terrible for their dental health. So here I am as a very well-educated person, and I'm still getting it wrong when I'm trying to make healthy lifestyle choices. So I think when we're speaking to our patients, we do need to take a step back and realise that things aren't easy for everybody, and nobody makes poor choices deliberately. It's usually a complex mix of reasons, and unless we can understand those reasons, it's going to be quite challenging for us to support patients to change their behaviour. The other thing that we see as a barrier for patients is this sense that those risks that we talk about, the lung cancer, the obesity-related cancer, the heart disease, the stroke, we're very good at thinking it won't happen to me, and giving examples of why it won't happen to me. So, well, yes, I smoke, but I don't smoke that much. And my uncle smoked 50 a day and he lived well into his 90s. And, well, yes, I do drink alcohol, but I don't drink spirits, and I don't drink in the house. I only drink when I'm out. I think there's all sorts of excuses people make, and this is quite a common psychological phenomena, that we're always looking for reasons of why other people might have poor health. We've seen that a lot with the COVID pandemic. People seem to be clinging on to the fact that it's only people who are at higher risk who get serious illness, and always looking for the reason that why somebody died from COVID. Well, that was because they were overweight, or that was because they had a certain lung disease. We're very good at trying to find reasons that things won't happen to us. And I think sometimes we need to support our patients into perhaps moving away from this falsely protective mindset. The reason that I wanted to bring that up as well, though, is as junior doctors, you really do have a unique opportunity, because more often than not, when you're encountering patients, they're seeing you because they have recently had a problem with their health. They want to talk to you about what's happened to them. Now, this means that it's an opportunity, really, because as we've discussed already, there's a fairly high chance that whatever's happened to them may, at least in some small part, be related to a lifestyle choice. Or at the very least, they could reduce further risks by making better lifestyle choices. So I think this really does present an opportunity for us to explore behaviour change with patients. And then we need to think, well, what's stopping us from taking on these opportunities? We're all seeing patients day in, day out, so why aren't we having these conversations? So I think there's a number of barriers that health professionals face, and some of these might be very familiar to you when you think about your own behaviour. The top one I think I hear time and time again is time constraints. We are all very, very busy at the moment. There's just no time really even to look after ourselves, let alone focus on the more peripheral aspects of our patients' care. You know, first priority is to make sure they're medically stable, and everything else feels like a bonus at the moment. But hopefully we can find some time to have very brief conversations. So we'll come on to that a bit later. Sometimes it might be a lack of confidence, not knowing quite how to phrase things or what skills you can use. And that might come from not having sufficient training in this area, or feeling that the evidence base might not be worth the effort, perhaps the effectiveness might not be worth the effort of having this conversation. A lot of people feel that there's other people who can take the responsibility for that. You know, perhaps it should be the job of the nurse on the ward, or the general practitioner, or somebody else entirely. And I think one thing that's a real concern for doctors is that we're trying to develop rapport with our patients. We're trying to show them that we're trustworthy, that they can tell us all their concerns. And yet, if we start talking about their lifestyle, there's a perception that we're going to be judging them, or they may perceive that we're being offensive, and it could negatively impact the doctor-patient relationship. So I think those barriers can be overcome, and I think we really should start thinking more openly about when and where we can use some skills to motivate behaviour change in patients. Really, it doesn't have to be just the realms of primary care. This absolutely can be relevant in secondary care. Thinking about it when you're having that first conversation with a patient, when you're taking the history, in many settings, you'll be asking whether the individual smokes, whether they drink. You'll be taking the information anyway, so it does open that door to have a conversation. A medication review, if they're on medications for chronic disease, then that can naturally lead on to this conversation. Discharge planning, you might want to be linking people in with services that they can use in the community. And of course, if we've got patients coming in for pre-op checks, those are absolutely golden opportunities to get people as fit as possible for surgery. We know that those patients who don't smoke and who don't drink and who have a healthy body mass index do better when we're talking about surgical outcomes. So I think one of the main problems is actually knowing that our patient is ready and receptive to have these conversations, to talk about information relating to behaviour change. And I would say this is probably one of the main areas that I'd like you to pay attention to, is where somebody is in their mindset about behaviour change. One of the tools I like to use is this cycle of change. And I'll be honest, the first reason that this appealed to me is, I think the first rule of behaviour change is that if somebody is not ready to talk about behaviour change, if they are not interested in it, then you just cut your losses and move on, because you'll be wasting your time and you'll be wasting their time if you continue to force an issue when a patient isn't ready. It's really key to know that, because you are very busy individuals, and so using your time efficiently is important. So when we look at this cycle of change, if you've got somebody who is in the pre-contemplation stage, it's not even on their mind, they're not thinking about it, then there is no point in having this conversation with them. Really, the ones that you're looking at are those who are in the contemplation phase. They can see that there are some benefits to making changes to their behaviour, and particularly those who are in the preparation phase. Now, these are the people who are just on the edge. They're about to jump in with both feet to making this change. And if we can support them and tell them some skills and strategies that they can use to make the change, they're going to be so much more successful than if they're trying to do this by themselves. If you encounter somebody who is already making changes, if they're actively doing it, then our role moves into more the supporting the maintenance of that, you know, encouraging them, congratulating them, using lots of positive language, reinforcing the benefits of the changes they're making, you know, motivating people to keep going with what they're doing, and showing, you know, how it's noticeable, the effect they're having. Relapse is hard. You know, patients always feel very disappointed with themselves if they've made a change and then it all comes crashing down around them. But it's very normal. Any change is difficult, and we should expect that it's not always going to be successful. The key thing is to support patients to realise, okay, it didn't go so well this time, but you did make a really good start, and these are the things that were going well, and just because it didn't work for you this time doesn't mean it's not going to work the next time. You've got to have sometimes several attempts at making this change before the one that sticks. So when you meet a patient, when you start talking about their lifestyle, it's worthwhile just trying to evaluate where they are on this cycle of change. I did say that if the patient is not ready to make the change, just move on. I would add to that even if they're not ready to make a change, it is absolutely essential that we still very briefly advise of the risks, and if possible, personalise that risk to their current situation. We should also, in a very non-judgmental way, then say, if you ever did decide that there was something, you know, there was something that you wanted to change about this particular habit, you know, if you did decide that you wanted to reduce your smoking, if you did feel that you wanted a bit of support with your alcohol, these are the services that are available for that. Now, the reason for this is that there has been some evidence shown that when a clinician doesn't acknowledge the risk of an unhealthy behaviour, or doesn't acknowledge that a person should be changing that behaviour, some patients will actually take that as approval to continue with that behaviour. So if you say to a doctor, yeah, I smoke 20 a day, and the doctor just writes it down and moves on to the next question, they will cherry pick that little interaction, and they'll say, well, the doctor didn't say anything about my smoking. If they were worried, they would have said something, and they will use it as justification to carry on smoking. So if somebody's not ready, yes, don't push them to have a conversation they don't want to have, but please don't just ignore it. One sentence can actually make a huge difference to this person's future. Everybody likes to know what NICE say about their particular area of interest. NICE actually have got quite a bit of information about behaviour change. If this is an area that you're interested in after today's presentation, I would encourage you to have a quick look at the NICE website. And really, as junior doctors, we should be focusing very much on the briefer aspects of behavioural change, because with the best will in the world, you don't have enough time to handhold patients through their entire journey of behaviour change. But you should be aware as doctors that there are short, medium and long-term consequences to poor behaviours for health. And you should be able to explain in quite positive ways that there are benefits of health enhancing behaviours. You should be able to support patients at different stages of changing their behaviour and recognise how their own social contexts can impact on their behaviour. And it is really good practice to think about in the future, you know, almost predicting that some people may relapse and trying to sort of build in some strategies to cope with that. We'll come on to that in a bit. And it's good practice for a lot of our patients to really set commitments. We see examples of this when you talk about organisations such as Slimming World and Weight Watchers, where people commit to a certain goal weight and they are more likely to achieve that weight if they've got it written down, if they're going for regular check-ins, if they've got accountability for their behaviour. But as I said, it's unrealistic for junior doctors to really be able to take on the full scale of behaviour change support. But I think it is realistic to think that we can take 30 seconds, maybe a couple of minutes with our patients to put a very brief intervention into place. And when we say very brief intervention, it's literally as simple as give a small amount of information, direct the individual for where they can go for further help, and then provide some encouragement for support and change. And this should be personalised as much as possible, thinking about that patient's own particular context, their social experience. You know, it may be, you know, so you mentioned you've got grandkids, you know, how do you think it would be for you if you're able to stop smoking? Wouldn't that be great? Because, you know, would that help you with your interaction with your grandkids? You know, often patients will bring their own ideas, which we'll come to in a bit. That's important for this. This is a strategy that's commonly used with smoking cessation support, the ask, advise and assess. So this is the idea of this is a very brief conversation. First of all, of course, you've got to ask if somebody is smoking or whatever health behaviour trying to focus on, drinking, exercise, and make a note of the response to that. And then, as I've said, advise strongly and clearly that quitting would be in their best interests. And then do try and personalise the advice. Now, this does rely on you having already developed a little bit of rapport. So hopefully this is coming more late on in a conversation you have with patients, and you may have picked up some information about their lifestyle, who they live with, what they do for a living, etc. And you can hopefully tie that in with your advice to the patient. And then assess, are they ready to make the change? And if they are, you as a junior doctor absolutely can be the one to refer or direct patients to the correct support, or at the very least say to them, you know, if you're ever ready to make this change, these are the routes that you can go down. And there is so much support out there. Every health board will have their own smoking cessation advisor. And I don't think anyone's ever done the number crunching, but when you look at the amount of premature deaths associated with smoking, you do wonder if the smoking cessation advisor may be saving more lives in a local health board than many of the other healthcare professionals working there. Most health boards also have adult weight management services with psychologists, dietitians, endocrinologists working for them. The exercise referral scheme has been hugely successful and has been set up nationwide to encourage people to exercise at their own pace, with specialists guiding them. And of course, drug and alcohol services are widely available as well, both through the NHS and in non-governmental organisations. And they can be very beneficial to help patients, even if it's with just harm reduction, or in particular, actually, they have a very good track record for relapse prevention, which is so important for a lot of drug and alcohol users. I think the main things when we're talking about how we communicate with patients, when we're talking about behaviour change, is the tone of language that we use. Patients will not take kindly to feeling that they're being judged. I think sometimes there's an expectation, you know, a patient who is a heavy smoker or a heavy drinker, by and large, they do know that a doctor is going to tell them that it's bad for them. It won't come as a surprise. So I don't think we need to worry about that element of the conversation, but it's the fact that they feel judged, or they feel that it's all well and good for the doctor. They don't know what it's like to live their life. You know, they might have so many complex difficulties in their world that we've just got no understanding of. So often it's useful to say to patients, you know, that you can understand why they've got to that situation, or talk in terms of when you've helped other patients who've been in this situation, what's worked for them is, and give some examples. Really, it's just trying to appreciate that everybody has their own issues, and accepting that people are adults, they can make their own choices for how they live their life, and we should respect their autonomy to do that. But we have a responsibility as healthcare professionals to advise our patients on ways that they can improve their health. If you're looking for some practical strategies, so for example, if a patient says to you, oh, I don't know where to begin, I don't know how to make these changes, I really want to, but I just don't know how. One of the things that I've found very useful over the years is thinking about these 4 Ds. So often when patients get an absolute craving for something, thinking particularly about smoking, that craving will only last a few minutes, usually between 6 to 10 minutes is the peak of a craving for a cigarette. So if they can do something to keep themselves busy, to distract themselves in that time, then that craving may pass and they may find that they don't need that particular cigarette. So just keeping themselves busy, if they need to pick up the phone, if they need to run on the spot, if they need to go out for a walk, just distracting themselves. So the delay strategy is actually saying things like, right, okay, well, I usually start drinking at 3 o'clock in the afternoon. I'm going to challenge myself to delay that until later in the day so that I have less time overall for that activity. Or, I'm not going to have my first cigarette of the morning when I'm still in bed. I'm going to keep my cigarettes downstairs so that I know that I have to be up and dressed and before I even have the first cigarette. So those sorts of strategies are designed to slowly reduce the amount of smoking, drinking, whatever it is that patients are trying to get to grips with. Deep breathing, so this is where we're sort of thinking more of the coping strategies. So if people smoke or drink, for example, because they've got an acute stress that's going on and they need something to help them manage that particular moment, then there's a whole range of relaxation exercises, the mindfulness skills that may help. It can be a challenge to get patients to take these on, but I've found that more recently there's a lot of mindfulness and relaxation apps that are available. And if you, again, sort of putting it back to the patient so that they feel in control, I'll often say to patients, well, why don't you have a look through the app store on your phone? You can see other people's reviews of the apps and you can see which one you think might work best for you or which one seems to match up with your way of thinking. Patients tend to feel more positively towards something if it's their choice to do it. So if they've chosen an app, it's more likely to be effective for them than somebody else recommending a particular strategy. And then there's the drink water. It's a bit of a simple one, but it does seem to help with cravings for smoking. And with alcohol, if you can try and encourage people to have a non-alcoholic drink in between every alcoholic drink, or perhaps having a lower strength alcohol to just try and reduce the overall harm, then that can be a more manageable approach than just stopping altogether, which of course can be quite risky. So thinking back now to the behaviour change, it does take quite a few elements to change your behaviour. You have to feel capable that you can do it. You have to feel that it's within your capacity to make that change. You have to have the opportunity to do it. You have to be in a situation where everything aligns, that you do feel that the time is right to make that change. And if you've got the opportunity and if you feel you've got the capability, that feeds into your motivation. The time is right, you're going to change that behaviour. So motivation is a really strong influence on whether or not people are able to change their behaviour. I was lucky enough when I was a student to have Professor Steve Rolnick working in Cardiff University. He is an internationally respected knowledge on the field of motivational interviewing. And what I like about Professor Rolnick's work is it is fairly realistic for what can be achieved in real clinical practice. Sometimes when you read information about psychological approaches to help encourage patients. You know, you can't help but switch off and think, well, this is all well and good if I had half an hour to sit and talk to a patient, but I don't have the time, and I'm not that person, you know, that's not my role anyway. I'm meant to be doing whatever else it is to look after their physical health, and I just don't have the capacity to talk somebody through the in-depth psychology of behaviour change. So motivational interviewing is a way of really trying to get the patient to bring their own ideas to the table for why they want to change, and using their ideas, the clinician helps them put together a reasoning and a motivation for making that change. I think it's fair to say that any strategy for encouraging behaviour change is only going to have low levels of success. Realistically, changing behaviour is very, very challenging. But when you're thinking about this, I often think it's nice to think about it in terms of number needed to treat. You know, we very frequently prescribe drugs to our patients that, you know, have ridiculously high numbers needed to treat. And I think this is a similar sort of mindset. If we have these brief conversations with almost every patient we meet, eventually when you're seeing tens of patients every shift, hundreds of patients every week, thousands of patients every year, you will have an impact throughout your career. So I think it's important to remember that although you're not going to change every single patient that you talk to, far from it, you know, you shouldn't be demoralized by that, because even if it takes 20 conversations for one person to change their behavior, you are having an impact. A couple of sort of tips then, thinking now more onto the practical side of this. Patients will be aware of the logical arguments of why they should change their behaviour. So those arguments, it's important to say, but they're probably not going to be the thing that sways somebody into making a change. Often people will feel really ambivalent about changing. You know, there will be some benefits of the risky behaviour to them, whether it's that they feel more relaxed when they smoke, or whether they sleep better when they drink alcohol. You know, whether there's something about food that provides comfort. You know, there's all sorts of positives to these behaviours, and so asking people to change, you have to overcome those barriers. So we want really any arguments in favour for change to be brought to the table by the patient, for them to tell you what the benefits are for change, and then you to reflect that back to the patient with a bit of extra emphasis from your clinical experience and expertise. It is better if it's done over repeated consultations where you can build on this, but I think in reality, this is just a sort of getting the ball rolling conversation that we're going to be having. I would say there's a tendency for doctors, I think it's to do with our time constraints as well, something called the writing reflex. So for example, a patient may say to you, oh yeah, well I do smoke and I do want to change because I know it's bad for me. And then immediately, before the doctor hears anything about why that person wants to change or why they perceive it to be bad for them, the doctor recognises there's an in there, that patient has said that they want to change. So they'll come on with several reasons. They'll say, oh yes, absolutely, I'm glad you said that, because if you stop smoking now, then your lungs will be so much more healthy, your blood pressure will reduce, so and we go straight in with the writing reflex. We give the patient all the reasons that they should stop smoking, but they're all our reasons, they're all the health system's reasons, and they're not personalised to that patient. So it's quite disengaging for patients to just hear exactly what they expect to hear coming out of your mouth. Reflective listening is the opposite to that. So, you know, if they say something along the lines of, well, you know, I really do want to stop smoking. It's costing me so much money, and you know, I've got kids I want to save for them, and you know, I've noticed if I'm out kicking the football around, then I'm getting more breathless, and I don't want to be that parent that can't play with their kids. So then you've got that little bit of insight. Then you can say, well, I can see this is a big step for you, but you've said so you've got children, and it's important to you to be there for your children, and to, you know, be the best version of yourself when you're playing with them. And I think you're right. I think stopping smoking would absolutely help you achieve that. And then it's more of a level conversation, you know, their priorities become your priorities, and they're more likely to think about how to change things. So we've got these 4 elements of motivational interviewing. The first element is the engaging. So this is the bit where, if we think back to our cycle of change, it's just where we're really trying to sound out how ready this patient is to make a change. Are we even going to pursue this conversation? So it could be something like, oh, you mentioned you smoke, and then a pause. Let's see what they say to that. If it's something that they want to have a conversation with you about, they probably will engage in that conversation. If they want you to move on, then you'll soon know. I think when we talk about weight, that can be a lot more challenging. People do feel that, you know, fat shaming is definitely something we're wary of. We don't want to upset or offend people. So I think we have to approach this sensitively. And, you know, we're used to asking patients if they've had a change in weight. You know, we're looking at those red flag symptoms for a lot of our patients. And quite often patients will say, oh, well, I know actually, if anything, I've gained some weight. So, you know, finish your history by all means, but then at the end you can say, so you mentioned that you'd gained some weight. Is it all right if we just talk a little bit about that? Because I'm wondering if that could be relevant to whatever it is that they've come in with. If you can tie it into showing why you want to talk about that you don't simply want to have a go at them, then I think that's a good way to reassure patients that this conversation is being held with their best intentions. Pick up on things that people say. You know, they will often give you the excuses for their behaviour, and then you can use those reasonings as part of your discussion. Hopefully, with those few sentences, you'll have developed a bit of an insight as to whether or not this person is ready to have more of a conversation about behaviour change. And then we come down to focusing. So if you've decided you're in for a penny, you're in for a pound, you're going to have this conversation with the patient, we want to focus them in. We want them to really think about this issue. So a question that they recommend in motivational interviewing is to find out, how important is it for you to make this change? So patients usually don't know how to answer this question, to be honest. They'll usually say something like, oh, very important, very important. So what we want to do then is really try and get them to analyse this a bit more. And a way that we can do that is say, okay, well, can you put that on a scale for me from 0 to 10? So 0 is not at all important, and 10 is like the most important thing in your life at the moment. And generally speaking, people don't say 0. Occasionally they do, and then maybe you want to just leave that conversation. But generally speaking, people will pick a number somewhere in the middle. And then the bit where they need to really think about it is when you say to them, well, why not 0? It's obviously important to you. So that then gives you some of the clues. They should hopefully give you some information about why it's important to them. And then you can take it a step further and say, okay, well, what would make it more important? What's going to push you up to an 8 or 9? And hopefully then they may give you some of their own motivations. They may not. They may, you know, these questions are quite challenging for a lot of patients. But it does really focus them on the subject. It gets them thinking about these changes. And next, this is really probably the most skillful part of the conversation, the evoking, how we actually get that little spark so that we're helping the patient transition. Do you remember at the start when we were saying, if you think you can or you think you can't, you're right. This is the bit where we're moving them from the thinking they can't to thinking they can. So the question we're asking is, how confident are you that you could make this change? And that usually gives patients a bit of a pause for thought, really, because it's an unusual question. They're not usually asked that aspect of this. How confident are you that you can make this change? And then say, well, can we put that on a scale of 0 to 10? How does that look when we try and analyze it a bit further? And hopefully, again, we're not on 0. Sometimes it is. Okay, so it's not a 0. Why not? So there's something there that's giving you a bit of confidence. And they may say, well, I have stopped smoking before. I managed to stop for 3 months before, so I know I can do it. Or, I know that there are times where I just drink out of habit and I don't need to drink. So I think if I can just, so I think this sort of thing will really make patients analyze their own life at that time and what the factors are that are impacting their confidence. And then again, we're sort of thinking about what will push you up a bit. Would it be support from an organisation? Would it be having some more information about changes? Might it be something like a nicotine patch or some, pharmacological support in terms of antabuse or, different medications that can help? There may be all sorts of things that will help increase people's confidence, but ideally it would be good for some of those suggestions to come from the patient. And then lastly, if we've got that far, if you've got somebody who's really sort of thinking, yeah, I'm going to do it, this is the right time for me. And remember, we're hopefully having these conversations with patients who are already on the brink of wanting to make a change anyway, potentially because they've come to see you with a health condition that's directly or indirectly worsened by their health behaviour. So what we want to do now is really just push them to gold standard planning. It is too vague to say, yeah, I'm going to do it. I'm going to stop smoking. We want them to be really specific. I'm going to smoke my last cigarette today and that is it. Or, I'm not going to buy another bottle of wine. I'm, having very specific statements of how they're going to change their behaviour. Even writing it down, we know that people who write things down tend to achieve a bit better and achieve their goals a bit better. The accountability, tell everyone, encourage your patients. If you really want to make this change, you need to tell people you're making this change and you need to ask them to support you. You need to say, right, I'm making this change. Can you please not smoke around me? Please don't offer me cigarettes. Please bear in mind that it's going to be difficult for me. So if I'm a bit more irritable, can you just bear with me? I'm hoping to get through this and be a better version of myself on the other side. Tracking progress, that can be a really positive way to do this as well. And the various different groups can do that. So for example, if you're the smoking cessation group, they'll often look at your carbon monoxide levels when you're breathing. If you're looking at the weight management groups, of course, they're going to be doing weekly weight checks for you as well. And then the other thing that I would say is often probably overlooked, but as we touched on before, one of the things that we can expect is that there may well be a relapse. People who, are doing really well, something will trip them up. So why not acknowledge this up front? Why not say to our patients, okay, that's good. I'm really pleased that you're going to make this change. What I want you to do is just spend a little bit of time thinking about what could trip you up, what could stop you, and really importantly, what will you do to try and avoid that, and what will you do if it happens? And really, we just want to get people into the mindset that all is not lost. If you have a bad day, if you have one cigarette, it doesn't suddenly mean that all your hard work is out the window. they need to stay in that mindset of no, that was just that particular moment and I'm still on the right trajectory. And I think patients that actually have that in-depth support, who come up with the ideas themselves and plan ahead in quite a specific way, are probably our most successful patients. But it does take a lot of effort, and it shouldn't be underestimated how difficult this is. And we should say to our patients, you know, it's not going to be easy, and hopefully with the right support in place, they will be successful. So it's a bit of a whistle-stop trip through some of the main areas of behaviour change. Of course, there's a lot more to this area of medicine, but I'm really trying to focus on the practicalities of life as a junior doctor, and knowing that you have very small amounts of time with your patients, but also recognising that you absolutely have a role to play. Doctors remain some of the most trusted professionals in society. Patients listen to our opinions. It's important to them to know what we think about things. So we should use that responsibly, and we should be able to support our patients to making these changes. We should realise that the vast majority of the patients have walked a very different path to us and may well have quite complex reasons for their behaviours, and unravelling all that to change their behaviour is often very challenging. But don't waste your time, but I said it before, but I do think this is important. You're busy people. If somebody's not ready to make the change, that's fine. Give them a bit of information and then move on, but do say something. Don't just say, oh no, this patient is so resistant, I'm not even going to say anything. Just one sentence that just makes them just have a little pause to go, oh yeah, okay, fine, I know I should change that. But if you say nothing, it can be very damaging. And then personalise it. Hopefully we talked about some strategies today that can support you to get the patient to bring their own ideas to the table of why they should change their behaviour, and then you can use those ideas in discussion with them for a collaborative approach that hopefully will be more effective. And realistically, you're not going to be the person that supports them all the way through this. There are other professionals with the training, time and expertise to take this on. So we should say to our patients, they're there, why not use them? The vast majority of them are entirely free, in a non-judgmental, supportive environment, and people do tend to do better if they've got support. So let's encourage people to use it. So thank you very much for your time and attention. I'm more than happy to field any questions, or if you want to email me directly, I'd be happy to discuss any of these aspects further. Thank you very much.
Thank you, Dr. Morris. That was an incredible talk and insight into the topic of behaviour change. Feel free to ask any questions, as always, on the FDoc Slack channel. We have a number of exciting talks coming up over the next few months, including ones covering the topics of transplant surgery and the Mental Health Act. Be sure to check out our channels at Medics.Academy to see what other resources we can offer for you. Thanks as always for tuning in, and I hope you enjoy the rest of your evening.